that you can hear me, you can say hi and you can proceed.
Okay, good afternoon. Greetings to you. Frederick, I think I can be able to get you clearly, and I hope that everyone else can. I don't know whether I can just proceed from here.
Yes, you can proceed.
All right, so the topic is antimicrobial stewardship, and we're going to look at uh, the scientific background upon which we're supposed to rely on as the scientists working in the laboratory setups, where the data that informs the situation, the global situation of antimicrobial resistance actually comes from. So as the primary custodians of antimicrobial resistance, or the primary source of this particular data, we are supposed to be informed of the pharmacological activities that these antimicrobials use against the organisms, so that now by then we can be able to understand the mechanisms by which the organisms now are using to counter the activities of those particular antibiotics or antimicrobial substances, or substances against them. So we are going to look at the pharmacology. I really want us to remember the basic medical sciences now, the pharmacology, microbiology put together with some surveillance and epidemiology, and we're going to be able to discuss this session here. Also, the objectives for the presentation will be on basically to review the basics of antimicrobial agents, classification and mode of action. We shall describe classical development of an antibiogram, and we shall be able to define what that is, highlight mechanisms of antimicrobial resistance, and then expound on medical laboratory approaches to antimicrobial resistance and ways forward. And that perhaps is our role now in AMS or AMR. And we'll be able to discuss principles, roles, and aspects of antimicrobial stewardship so that we can be able to implement this in our setups and ensure that there is a proper use of antibiotics, especially antibiotics. Now, antimicrobial agents, what are these? These are substances that are used to, either to kill or to stop the replication of microorganisms. They are classified depending on what they are going to work against. So we have antibacterial, we have antiviral, we have antifungal, and we have antiparasitic. Also classified again according to their spectrum of action, whether it could be narrow spectrum or broad spectrum. It could be classified according to the mode of action, which we find that some are bactericidal, they kill bacteria directly. Others are bacteriostatic, or they stop the replication or the growth of bacteria, and then leads to its elimination like that. And this work through interrupting cell wall synthesis, nucleic acid synthesis, and protein synthesis. Then classification, of course, this just one or so examples against each and every class of antimicrobial substances. And antibiotics are also called antibacterials. They act against bacteria, and an example is penicillin, which is among the first antibiotics to be discovered. Antivirals work against viruses, and an example is acyclovir that works very well for people with cytomegalovirus and some hepatitis and other viruses. Antifungals include amphotericin B, fluconazole, and the likes. Amphotericin is a systemic antifungal, and there are others that are topical or maybe organ-specific or maybe region-specific antifungals that work locally. And then antiparasitic, such as the metronidazole, we're talking about artemether, lumefantrine, those ones that act against malaria parasites. They are just examples of antiparasitic drugs. And all these are antimicrobial agents. Now, there is resistance in all these groups of antimicrobial agents. but we're going to concentrate on antibacterial because this is what is the most common. Now, as we mentioned, there is a bactericidal activity or bacteriostatic, which have been explained here, killing or inhibiting the bacterial growth. Then mechanisms are here. Mechanisms of antibiotic actions are here. There are those which work against the cell wall synthesis, others work against the nucleic acid synthesis, others work against protein synthesis. So that's basically it. Beta-lactams work against the cell wall synthesis, and these are beta-lactam antibiotics, such as penicillin, cephalosporins, carbapenems, monobactams, and then vancomycin as well, and bacitracin, and then polymyxins. These ones are against fungi. These ones are antifungal. Then folate synthesis such as sulfonamides and trimethoprim. They are usually combined. And then 30S subunit, targets tetracycline and aminoglycosides. And then 58 subunit to have macrolides such as clindamycin, dinazolide, chloramphenicol, and streptogramins. Then nucleic acid synthesis such as quinolones and rifampicin. This one works very well for people with tuberculosis as well. So these are the mechanisms against which the antibacterial agents are going to work against this particular bacteria. This one is a bacterial cell. This one's a bacterial cell. All right. These are just examples of antibiotics that are going to work against the cell wall. I think we've already mentioned that in the previous slide, but I'm just mentioning beta-lactams, such as penicillin, cephalosporins, and the carbapenems, and vancomycin and bacitracin, protein synthesis inhibitors, aminoglycosides, tetracyclines, macrolides, and chloramphenicol, nucleic acid synthesis inhibitors such as quinolones, and DNA, RNA. This one, quinolones work against the DNA, and then rifampicin works against RNA, nucleic acid. Then metabolic pathway inhibitors such as sulfonamides and trimethoprim, which work against the folic acid synthesis pathway. And then we have cell membrane disruptors like polymyxins and polines, which are antifungals. So these are basically the classification of those particular antibiotics. And perhaps we can be able to know that an example for penicillin is this one here. Yeah. And an example of, I'll not mention on this, but maybe just a simple definitional, definitional aspect of a difference between antiseptics and disinfectants, and it's here that antiseptics are applied on living tissue, and they include these ones here, and disinfectants are applied on inanimate objects or surfaces to kill microorganisms. So they include things such as bleach and phenol. So alcohols on living tissue and iodine, and we can see this one being used in the hospital. So you wonder why they're not using bleaches on someone's skin and phenols on someone's skin. They're all going to work the same way, but this one they're corrosive and they can be able to harm the living tissue. So that's why we use these ones here. Then broad spectrum act against a wide range of bacteria, both gram-positive and negative, and narrow spectrum act against a specific group of microorganisms. Examples of individual drugs, because these are what we are testing against anyway. If you are doing antimicrobial susceptibility tests, then these are the antibiotics that you are using in your setup. And microbiology becomes very difficult if you've not mastered the classification of organisms, for example, because there are drugs that are going to act against gram-positive organisms. There are drugs that are going to act against gram-negative organisms, and there are drugs that are set specifically for site-specific infections. For example, if there is a urinary tract infection, there are drugs that are going to be added to the AST panel for those particular organisms that you have isolated in the urine. And if you isolate the same organism from, for example, say from a respiratory sample, there are some drugs that are going to be excluded from that particular panel because of the different activities and the different setups in which the organism is residing. And these have been, of course, proved scientifically, and that's why there are guidelines, the standard guidelines on how you can be able to select different antibiotics against different organisms that you've actually isolated, which means that microbiology is a um, highly coordinated manual activity where you're supposed to link the gram stain, you're linking the biochemicals, you're linking the organism now identified to everything up there. You're linking it to even the clinical presentation of the patient, because there are some pathogens that are going to be isolated from a specific site that are normal flora elsewhere, all right? But if they are elsewhere, they are pathogens. So you're going to link it up all together. Then you're going to link the organism isolated to the antibiotics you're going to select in that particular case, following the Clinical Laboratory Standards Institute or CLSI guidelines, or some people use UCAST guidelines, and your practice becomes very, very, very much reproducible and very standardized. So these are the drugs that we're talking about. And as we mentioned, penicillins, they're all over here. Such as some combination exists, such as piperacillin and tazobactam, and I've seen it. I have it in my setup. Then cephalosporins, which are divided from the first to fifth generation. They were fourth, but fifth generation has been added, and with the increasing spectrum of activity. So the first cephalosporins have very narrow spectrum of activity, and then the spectrum increases like that. So these ones primarily will act against gram-positive, and then as they increase like that, they'll extend to gram-negatives and other organisms that are difficult to handle. So first generation cephalosporins include cephalexin and cefazolin or kefazolin, depending on who taught you. Then second generation cephalosporins include cefprozil, third generation ceftriaxone, fourth generation cefepime, and then fifth generation, we have ceftolozane, which has been just added as another drug in that particular category. And they have increasing spectrum activity with the increasing generation. Carbapenems, we have imipenem and meropenem. I think these ones we've seen, which are reserved also. They're very strong antibiotics and very expensive as well. So they are also reserved. If you're finding that your organism is responding or is sensitive, is susceptible to other antibiotics that are mostly available, especially these cephalosporins, release that one, and reserve these ones here, so that now they can only be used in cases where there is no other option. Aztreonam is another one, which is a monobactam. Sulfonamides, trimethoprim and sulfamethoxazole. All right. Fluoroquinolones, we have levofloxacin. And then macrolides, erythromycin, azithromycin, clarithromycin, those ones. Then aminoglycosides, we have streptomycin and gentamicin. Then tetracyclines, we have tetracycline itself. So these ones are the broad classifications of antibacterial drugs. This is the same classification and the mode of action. And this, perhaps I needed to mention this particular image here. This is an image of a bacteria. This is an image of a bacteria that has just, it's exposed to different antibiotics, for example. An antibiotic is coming in, it's going to be exposed to different plasmids, and then this antibiotic can either be degraded by antibiotic degrading enzymes here to release particles that are not going to be effective, right? This antibiotic here. So this one mode of resistance. Then an antibiotic can also be, altered. It can be altered by different enzymes and rendered ineffective. So the bacteria will still continue surviving. Then there are efflux mechanisms where the antibiotic is continuously, extruded from the cell, so that it's not remaining where it's supposed to be working, but it is just being expelled back to the outside environment, and it's going to remain infective for this particular bacteria. A brief on antibiograms. Antibiogram is a set of antibiotics that are going to be used in that particular setup for that particular organism. So we may have E. coli that's isolated in Bungoma or in Western where I live, and E. coli that's isolated in Mombasa, which are behaving very differently when exposed to different antibiotics. So that's why an E. coli that's isolated in Kisumu might not be the same E. coli may not be having the same resistance patterns as the same as E. coli that's It's been isolated from Nairobi, for example. That's why there are antibiograms in place that are guide local practice of antibacterial, prescriptions and all those kinds of workups. So these are things that are developed over time, not after a few AST data. You'll develop an antibiogram over time. Could be a year, could be 2 years, depending on the workload as well, and depending on the regional microbiological setups, so that now you can have antibacterials that are going to be used by the clinicians in your setup like that. And this is actually the standard practice in antimicrobial stewardship. Very, very important to get hold of it. So for example, here, um, you can use a variety of samples. There are people who have a privilege of receiving samples from everywhere. They are getting blood samples, blood culture samples, they're getting urine samples, they're getting stool samples, they're getting fluids, yeah, including CSF, aspirates, and everything. They're getting pulse swabs. Those are very good because you have a wider panel from which you can be able to compare the resistance mechanisms from all over the place. And then you can be able to develop an antibiogram that's going to be effective in your setup like that. There are also people that also include the IPC swabs that are usually swabbed from different sites in the hospital or in environments, and they include it in the antibiograms, which makes it very, 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 very widely applicable because it is coming from a wide range of information. So you put it together, and then it can be able to form something like this one here. I think you can see an example of an antibiogram up here. And it is we have an organism called Acinetobacter baumannii here, and another one called E. coli. Yeah, you can see that there are different antibiotics up here, and there are different susceptibility patterns. For example, against amikacin, Acinetobacter, it's a normal. I mean, it's non-pathogenic for people who are having the normal immune system. But if you are immunocompromised, or maybe it's those people who have been hospitalized for long, those ones who are in ICU setups, they are going to have this organism being one of the pathogens, especially if it is introduced into the bloodstream through different modes, maybe through a needle prick or during ineffective IPC measures by the people working in ICU. So these are the profiles. After a while, after a long and different isolations of these ones, and actually exposing it to different amicacins and different at different times, you'll be able to come up with an average susceptibility profile. And this one is a good one because the number that was used to get this one was for 41 isolates, and they were 90.2% susceptible to amikacin, which is very good. 84 cases of E. coli isolated, and they were all susceptible to amikacin, which is very good. You can get another antibiotic here. For example, Acinetobacter baumannii is poorly susceptible to amoxicillin. And this is the number of isolates that were used. And this is the number of isolates that were used. And this is, so you can compare the way different antibiotics are susceptible or resistant, and you can be able to develop an antibiogram or a list of antibiotics that are going to be set up in those particular areas, including the dosages, including the drug route of administration, and when to discontinue and when to change the antibiotic. So that's why it involves a different set of people to come together to form this particular antibiogram. But the data comes from the daily antimicrobial susceptibility tests that we do in our labs. Now, mechanisms of resistance, we have intrinsic, such as lack of receptors and all transport channels across the cell membranes. We have acquired resistance, such as increased, which are increased because of these particular reasons here. Acquired resistance is what perhaps we're supposed to intervene. The human intervention now comes in here, where healthcare workers now can be able to either influence an increased resistance pattern or a reduced resistance because of different reasons here. So, for example, there is an increase in abuse of antibacterial drugs, which you can be able to by only using antibiotics when it's supposed to be used or for bacterial infections. When you have abundance of bacteria in human as compared to other microorganisms, then there is more prevalent bacterial infections, of course, which means that there are more frequent prescriptions of antibiotics as compared to antivirals or antifungals. Then pharmacological, which we're talking about potency, spectrum of activity, even compliance by these particular patients, which we're supposed to come in and also help in compliance. Educational factors such as people understanding the pharmacokinetics and pharmacological basis of these particular antibiotics so that we cannot be able to abuse them. Then regulatory side, where only antibiotics that have been prescribed by the doctor are going to be sold over the counter, or there is not going to be over-the-counter selling of antibiotics. Of course, financial reasons, and that one is self-explained. So, individual mechanisms of resistance, we're going to look at the genes, we're going to look at the enzymes and other mechanisms that are going to lead to antibacterial resistance, so that as scientists, even people who are in research, because we understand that the rate at which new antibiotics are being manufactured is actually not as high as compared to the rate at which antibacterial resistance is being experienced. And actually, antibacterial resistance and infectious diseases is top 3 global public health issues, just third from maybe chronic diseases and maybe mental health and environmental, maybe climate change. Antimicrobial resistant and infectious disease is the third, that most prominent global burden. So you see that we're dealing with a real issue that's going to be influencing a lot of lives. And we see that there is increased death because of antibacterial resistance, where there is no more options for antibiotics. And a simple infection with E. coli will be able to kill somebody because there is no treatment. Yeah. You are helpless. If it is resistant against all the antibiotics that you have, so you're not going to be able to treat it. So we're going to look at the mechanisms, and perhaps the guys who are in microbiology, and doing research in AMS, perhaps you can be able to look at these genes and maybe how you can be able to work around them so that they can be able to they can be reduced resistance because of this particular instance. Because first we understand why it is coming, and then now device mechanisms against which you can be able to reduce AMS or antimicrobial resistance. So there could be presence of an alternative enzyme for the enzyme that is inhibited by the antimicrobial agent, right? So that enzyme is going to lead to increased, usual activity in the bacteria as compared to what the bacteria was the antibacterial agent was targeting. Then a mutation in an antimicrobial agent's target, which is a common thing here, it reduces the binding of the antimicrobial agent. Then post-transcriptional or post-translational modification of antimicrobial agent. This one, we can't help it. The antibiotic has already been broken down. It is in the active form, but it is transcribed or changed. The form is changed because of maybe other interactions with the other chemicals or other things in the human body that renders it ineffective against the bacteria. We can't have much to do with that, but we can be able to maybe work on the targets here. Then there could be reduced uptake of the antimicrobial agent, and then there could also be active efflux or active pumping of the antimicrobial agent outside the cells. And then that one will be rendering it ineffective. Then when you do your AST, you're either getting intermediate or you're getting resistant. Then overproduction of the target of the antimicrobial agent, and we end up having a lot of targets and little antibiotic in the system, and they are rendered ineffective. Expression or suppression of gene in vivo in contrast to what is the situation in vitro. So there could be genes that are only available, that are only working on the bench, yeah. So that now, if you introduce the drug in the body, now we have other enzymes, other genes that were not studied, working against that particular antibiotic and also causing its reduced potency. And now other mechanisms are also unknown. Perhaps that's why there is active research in this particular area. Individual resistance patterns, we're going to look at the classes of antibiotics and the individual resistance patterns. I'm mentioning briefly as we go because there is antimicrobial stewardship later on to handle. Then beta-lactams work, of course, the mechanism of action is they work by, of course, they have a beta-lactam ring, and they work against the cell wall, the cross-linking of the cell wall, and they target the penicillin binding protein, right? They rely on the ability to reach and interact with the penicillin binding protein, or the BPP. Now, so that if there are changes in this BPP, the beta-lactams are going to be useless in this particular case, all right? So the resistance is due to hydrolysis of the antibiotic by beta-lactamase producing organisms, and we'll be able to see some of this, and modification of the BPP, the penicillin binding proteins or cellular permeability. So this is very simple, just like that. Penicillin binding protein and the beta-lactamase producing organisms. Then they cause resistance to beta-lactams. And there are many. There are penicillins, cephalosporins, and the carbapenems. All of them the same mechanisms of resistance. And then tetracyclines, and these ones work by preventing the attachment of amino acid transfer RNA to the ribosomal acceptor site, perhaps now inhibiting protein synthesis. And they are broad spectrum, of course, working against other organisms such as chlamydia, mycoplasma, and rickettsia, and other protozoa parasites. And they include tetracycline, doxy, and minocycline, and oxytetracycline. So these tetracyclines are the ones that are in these groups, yeah? Mechanism of resistance is the efflux, especially by from the major facilitators family of proteins, and these are efflux genes. And then, of course, ribosome protection occurs also through ribosome protection proteins that protect the ribosome from the action of the tetracycline. So there is efflux mechanisms through the MFS superfamily, and then ribosomal protection, where these proteins, the bacterial proteins, are protected against the tetracyclines. Then we have chloramphenicol, which acts against, binds to the 50S ribosomal subunits and inhibits the peptidyl transferase step in protein synthesis, of course. And resistance is due to the inactivation of the antibiotic by chloramphenicol acetyl transferase. And some of the genes described here are the CART genes that are found in gram-negative and gram-positive bacteria, and they show homology. Other mechanisms are active membrane permeability or active efflux. So for chloramphenicol, it's just an inactivation of the antibiotic by chloramphenicol acetyl transferase via these particular CART genes and efflux mechanisms. Aminoglycosides, they have amino acetyl ring that's linked to amino groups or amino sugars in their structure and have a broad spectrum activity. They include streptomycin, kanamycin, gentamicin, tobramycin, and amikacin. And I've seen people interchanging amikacin, gentamicin, tobramycin, kanamycin without AST. Perhaps for you to determine that this is the best aminoglycoside, you have to have this one in your setup, and you can be able to do your AST and determine. And then the bactericidal activities attributed the irreversible binding to the ribosomes. Then more than 50 aminoglycoside modifying genes have been described, and they're mostly associated with gram-negative organisms. So these enzymes can be classified either as aminoglycoside acetyl transferase or ASC. aminoglycoside adenyl transferase, or it's also called aminoglycoside nucleotide transferase, or ANT, then aminoglycoside phosphotransferase, or APH. So these are just transferase enzymes that are going to change the structure of the antibiotic, yeah, and rendering it ineffective. And mechanisms of action is because of this ASCC, ANT, and APH enzymes that lose their ribosome binding ability and thus no longer exhibit the protein synthesis. Then efflux system is all over the place. Efflux. Almost all antibiotics are extruded from the cell like that. Fluoroquinolones have a fluorine atom at position number 6 of the quinolone molecule. Then they have enhanced action against gram-positive and negative bacteria. The agents exert their antibacterial agents effects by inhibiting certain bacterial topoisomerase enzymes such as DNA gyrase, which is a topoisomerase enzyme 2 and topoisomerase 4. So quinolones are directly working against DNA. Mechanisms of resistance are altered drug targets. And then in gram-negative, we have DNA gyrases that seem to be the primary target for all quinolones, of course. And these gyrases could have, mutations. So, and then amino acid substitutions within the quinolone resistant determining regions of QRDR involve the replacement of the hydroxyl group with a bulky hydrophobic residue. Then mutations in the GYR-A induces changes in the binding site, conformational, and all the charge that may also be important in quinolone and DNA gyrase interaction. So GYR-A and differences or changes that may occur in the quinolone resistant determining regions. Those are the mechanisms against which quinolones are going to be resistant. Glycopeptides are comprised of peptide antibiotics of clinical interest, such as vancomycin and tecomycin. These ones work against gram-positive organisms, such as staphylococcus and streptococci, and those, cocci, mostly cocci. The antimicrobial activity is due to the binding of D-alanine side chains of peptidoglycan or its precursors, thereby preventing the cross-linking of the peptidoglycan chain, and thus are largely used against gram-positive organisms because of the large peptidoglycan layer in gram-positive organisms. Yeah, well explained like that. Then high level of resistance to vancomycin is encoded by Van-A gene, all right, that results in the production of Van-A, which is a ligase that results in the rebuilding of the peptidoglycan side chains by the expression of D-alanine D-lactate type, which has less affinity for glycopeptides. So Van-A, which is just vancomycin, yeah, for you to remember, this is vancomycin, Van-A, and others are Van-H, Van-X, and Van-B. So those are some of the genes against which resistance develops for vancomycin and other glycopeptides. The last one, I think, is sulfonamides, and then we shall be able to look at and methicillin, which is for gram-positive cocci, and especially Staphylococcus aureus. So for sulfonamides, resistance is commonly mediated by alternative drug-resistant forms of dihydroate synthase, or DHPS. And it is because of this particular genes here, SAL-A or SAL-2, which is just sulfonamides. These genes are just abbreviations of these particular drugs. So you remember the drug, the class, you're going to remember the genes with which mutations, with which resistance is going to develop. So SAL1 gene or SUL1 gene is normally found linked to other resistant genes in class 1 integrons, while S2 genes is usually located on small non-conjugative plasmids or large transmissible multi-resistant plasmids. and they work against the mechanisms of resistance is because of the inhibition of the enzyme dihydrofolate reductase, of course, which is the reduction in the spectrum of activity of trimethoprim. It is a resistance due to the overproduction of the dihydrofolate reductase, yeah, which now, or mutations in this structural gene for DHFR acquisition, or DFR gene, which encodes for DFR enzyme, which is the most resistant mechanism in the clinical isolates. So people in research, these are some of the genes that you might want to look at if you want to improve the functionality of sulfonamides. And for people who are doing AST, by the way, I've seen that most of the gram positives are resistant to these sulfonamides. Yeah, together with trimethoprim or trimethoprim and sulfonamides as a combined drug. So perhaps this is one of the things that's supposed to be hitting people's heads. And while you're doing your research proposal development, perhaps you can think about this and you can get funding to do your research in very good labs and improve the functionality of such kinds of drugs. Then methicillin resistance is because of methicillin resistant Staphylococcus aureus is a difficult one. And it emerged shortly after introduction of the methicillin drug in 1959. And it is precipitated by MEC-A and MEC-C genes within the Staphylococcus cassette chromosome MEC, or SCC MEC. So it demonstrates MRSA demonstrates resistance to beta-lactam antibiotics through an altered penicillin binding protein that maintains cell wall synthesis despite antimicrobial pressure or use. So that's why we're not going to use penicillins in these particular cases, but we're going to use other antibiotics. They're going to target different mechanisms, such as vancomycin and clindamycin, which are going to be used in this particular case here. So you set up your AST, you'll see that AST for Staphylococcus aureus is going to be exclusive of those particular cephalosporins because of the integral penicillin binding protein that's altered already. Yeah. So MRSA adds to that particular burden. Apart from having an abnormal PBP, there is also MEC-A gene that is driving resistance to other antibiotics, such as methicillin. And mostly you'll find that also vancomycin might be resistant, or clindamycin might also be resistant. But sometimes, and most of the time, you'll get that they are also susceptible. So you can also, after isolating your Staphylococcus aureus, you can also test to determine whether it's an MRSA or it is not, for you to report it and for the clinicians to make their decisions. Now, medical laboratory approaches. What is our role? I think people have already handled this, but the scientific background perhaps is what was actually supposed to be highlighted in this presentation. So that if you're talking from our role, now we understand that this is what happens if we are going to misuse drugs. And these drugs are resistant because of this and this and this. And these antibiotics are effective against this particular bacteria because of this and this and this. So that's why we need to be informed and perhaps practice our microbiology from an informed point of view. And these approaches are multi-layered strategy that combines traditional, molecular, and advanced technologies to identify resistant pathogens and determine optimal treatment and do surveillance and even do clinical research, because that's where we are. We're in the medical labs. And I'm glad that there are people who are having PhDs in microbiology, PhDs in virology, in mycology. Those guys, I think this is very, very good because people have come up and are picking up these particular roles very strongly, and the research part is actively being done in our clinical labs. Then the medical laboratory is the constant cornerstone of AMS programs and provides data that guide treatment, reduce empirical approaches to antibiotics, and also inform on policy development, also inform of the burden of antimicrobial resistance and every other thing that may come from the information that we also provide from there. We can also provide information from which antibiograms are going to be developed from the laboratory. So that's a lot of information that comes from us. And Conventional methods with which we provide that information is through these ones here, right? We can be able to measure the presence of we can be able to determine the presence of bacteria, and also determine the susceptibility of this bacteria, whether they are susceptible, whether they are intermediate, whether they are resistant. We can demonstrate this and determine it in our labs using standardized clinical guidelines by CLSI and UCAST. So this includes things such as simple gram staining and biochemical tests, which should correlate with the organism that you are actually identifying. Some people are using automated systems, others are using manual systems. I believe that if you come from a manual system, I think this is a very good chance for you to learn, because when you've done something manually, then you'll understand the automation bit of it, because automation nowadays makes people relax. But if you have done manual gram staining, manual biochemical identification, and even manual ASTs, it's very important so that you can be able to understand actually what happens in these particular cases. Then we have identification of the individual antibiotics that are going to be used in these particular cases. We can be able to determine the resistance patterns using minimum inhibitory concentration of or MIC. We can use disk diffusion methods, or the Kabibauer methods. And here we can demonstrate whether organisms are extended beta-lactamase producing organisms or they're not, especially for gram negatives. And the Enterobacteriaceae family of gram-negative bacteria are particularly a headache here, especially E. coli, and we're talking about others like Klebsiella, Pseudomonas. They are very, very important pathogens, which are supposed to be describing whether they are extended beta-lactamase producing organisms or they are not, so that the drugs of choice are going to be combined depending on how they are behaving on the discs. Now, methods that exist in testing for ESBL or extended spectrum beta-lactamase production are like combination disc test, where discs are already combined. ESBL, we saw that beta-lactams are penicillin, cephalosporins, and carbapenems. So cephalosporins are the most commonly used, and they're the ones that are usually commonly used for testing of ESBL, or of course in combination with clavulanic acid. And we can be able to talk about augmentin or maybe amoxicillin and clavulanic acid put together, which are used in the second type of ESBL testing, the double disc synergy test. We will be able to observe something like a keyhole-shaped structure that is tending towards the augmentin. Your augmentin. You put it at the middle of the disc, the MHA disc, after, of course, you've inoculated the organism. And then on the side, you can be able to put one of the cephalosporins. You can use ceftazidime or cefotaxime as a cephalosporin with which you're going to test with the augmentin that you put at the middle there, so that now we can determine whether these organisms are ESBL or they're not. Then MARSA or MRSA, which are methicillin-resistant Staphylococcus aureus, you can be able to test for that using cefoxitin and oxacillin discs. We can be able to use gradient strips, such as e-tests, of course, with a gradient of antibiotics in advanced labs. And then we can be able to also use automated systems. Nowadays, you just put your sample there. You'll be notified when there's a growth. IT and information technology, I'm telling you. You'll be notified that there's a positive growth here for you to do further workups now and do the subculture and perhaps now do the identification of these particular organisms on platforms such as Vitec and BD4NX and MicroScan. These platforms are also automated. They choose the antibiotics against which they're going to work. If you have isolated your E. coli, and then there's a panel for E. coli as an organism, a panel of drugs for E. coli. You have isolated your Staphylococcus aureus. There's a panel of drugs for Staphylococcus aureus, and you're going to get the resistance or susceptibility pattern after your incubation period has elapsed. Then molecular methods include things such as polymerase chain reaction that test for the presence of these particular genes here, or maybe whole genome sequencing of the bacteria or viruses. Yeah, there are people who are doing researches and doing whole genome sequencing of an organism to determine whether there are any genes that have been, omitted in the previous versions or they are not, so that they can determine even new targets for different antimicrobial organisms that were not known before. And this is the kinds of research that, guys doing PhDs and those advanced degrees are actually doing. Other things are like Gene Expert, a point of care test for resistance against rifampicin for those particular Mycobacterium tuberculosis. Then how can we be able to use those information from the lab? We can use it for surveillance, such as the developing of antibiograms, the use of WUNET software, which is commonly used in AMR. And then we can be able to have coordinated surveillance networks between private and public hospitals, between private and public labs, between between agricultural and health institutions, between food and human health nutrition, departments, so that you can, compare the resistance patterns, because it does not only affect humans. Resistance goes to animals and it goes even to agriculture. So that now we need to think from it from a wider perspective, not just from the clinical isolates that we're getting from our blood or urine or sputum samples. We need to think of the environment from which these particular organisms are coming from. And when we do environmental swabs, which come back to the clinical labs, is going to provide the information so that there is coordinated surveillance programs and there is a wider, perspective from which we can be able to view the antimicrobial resistance patterns. Then, of course, information exchange. Some places might have the highest isolation, highest isolated organism could be Staphylococcus aureus, for example, in one region. You go to another region, you're going to get Klebsiella, for example, is the highest isolated organism. You get to another one, there's another profile. So those kinds of information changes, and also information to do with the IPC practices, random swabbing of surfaces, surgical surfaces, sinks everywhere in the hospital. You can be able to tell that this is an effective IPC practice in this hospital or it is not, depending on what grows on those particular swabs. Prevention of antimicrobial resistance, we can prevent it by preventing over-the-counter sale of antibiotics, except when given with a prescription. Then advocate for completion of doses, especially for those long-lasting prescriptions, such as for TB. People may be given a dosage for 3 months, 6 months, and even beyond, and compliance becomes very difficult. Then reduce overprescription of antibiotics to cover things such as colds or viral infections. Then implement directly observed therapy. This is where we have a healthcare personnel looking after a person who is taking antibiotics. There are people who are doing home-based care and they can be able to do these things very much for those clients who are known to be non-compliant. Other people, when you give them drugs, they're going to throw them away or they're not going to take them all together. So directly observed therapy becomes very important in those cases. Then standardized microbiology practice following CLSI and UCAS recommendations. This is very important. And this is basically lies on us and we're supposed to be informed. And then selective reporting of AST. Very, very important. So that if you've seen that this is a reserved drug, and there are other drugs that are susceptible in your panel, please report those ones and reserve the ones that are reserved, the ones that are used as last options. Astronium, things such as imipenem, meropenem, you don't just report them routinely. If there are cephalosporins in your case that are susceptible, report those ones. Let the people go and prescribe those ones and leave the highly reserved antibiotics for special cases or resistance. The last bit, now that we've understood the science of antimicrobial resistance, and then what is this program that's going to help put it together and curb the antimicrobial resistance? We're calling it antimicrobial stewardship. And it involves coordinated evidence-based systematic use of antimicrobial agents to optimize clinical outcomes, minimize resistance, and reduce costs. Because if you're treating someone and they're not getting well, you're going to admit them in this hospital, you're going to take them to another hospital, and they're not going to get well because the antibiotics are the same. If you're going wherever you're going, the antibiotics are the same. So if the person has an infection that's resistant to a multiple a multitude of drugs, then you're going to have very increased costs in capping that particular treatment, perhaps just maintaining the health of the person. Then MS focuses on selecting appropriate drugs, dose, route, and duration. The 4Ds which are here, the right drug, right dose, and right duration or de-escalation, where you're supposed to stop the antibiotic at the right time, avoid overuse, then right delivery or right route. If it is oral, if it is intravenous, if it is intramuscular, you determine those ones. And that's why there is antimicrobial stewardship teams in hospitals made up of microbiologists, made up of clinicians, made up of infectious disease specialists, made up of public health, officers, and people in strategic management positions, such as finance or directors, or those kinds of people who can be able to help make decisions and also provide, finances or maybe facilities that are required to ensure that there is a working antimicrobial stewardship program in their particular setup. Another aspect of antimicrobial resistance or stewardship is the 5 Rs, which is the right patient getting the right drug, getting the right dose at the right time for the right duration. So 4Ds and 5 Rs are the key aspects of antimicrobial stewardship. And these Rs cannot be determined without antimicrobial susceptibility tests that comes directly from the clinical labs where we work. So you see, the information that you're releasing is not just a routine work in your microbiology labs. It is going to be, incorporated into so many other things, and it's going to come in the assessing the antimicrobial resistance patterns in the country or in the counties, for example, or localities such as African continent against other continents. And it's because of the data that you're producing in your labs. So as you release those data, you know that you're going to release something that's reliable so that as people are going to depend on that information to make choices or decisions that are going to be critical for your human health, then you know that you're doing the right thing. It has come from you and you did it the right way. You're not going to release just shoddy work to make misinformed decisions later on, and programs are going to be poorly implemented because of the poor work that you actually gave out. Core principles includes diagnostic stewardship where we are there, and you release reports to confirm infections, to treat patients, not just releasing lab works. People just release values, sentences, without putting the patient in picture, without putting the aftermath of this particular events in the picture. So you release a report that's going to be directly applicable to your patient, directly applicable to people who are going to make decisions to cap this antimicrobial resistance. Then antibiotic timeouts or reviewing treatments after, at certain period of time, 2 days, 3 days, to stop or to change based on the progress of patients. So this is in the clinical team and in the wards. Then prevention action, where we have utilization of infection prevention and control measures to reduce the need for antibiotics. When we are washing hands, when we're washing our surfaces, we're not going to be sick. We're not going to ingest E. coli. We're not going to get bloodstream infections. Yeah. We're not going to get our food contaminated or our water contaminated. So this one will prevent the use of antibiotics altogether. All right. Because you're using clean water, you're using clean food, you're using surfaces that are clean and everything like that. So you're preventing the use of antibiotics even altogether like that. Then implementation of AMS requires strong leadership commitment, pharmacist pharmacological pharmacist expertise, microbiological expertise, and monitoring and reporting of usage. Then relevance, of course, antimicrobial resistance is a top 3, as I mentioned before, is a top 3 threat to human health, just third after the chronic non-infectious or non-communicable infection, non-communicable conditions, and climate change and environmental conditions, such as maybe poor weather, hurricanes. Those are things that are killing people all over the place. And this one comes number 3 on it. Topping cancer and all the other things that may be able to cause infection. So AMR is a global issue, and we're supposed to come in together and help curb it or curb it. Then this is the last slide, and it's looking at the antimicrobial stewardship itself and how you can be able to implement it in your setup. And we have these components here where there is a research and development as a component of antimicrobial stewardship. And these are the people in academia. You could be in academia and also in clinical practice, and you're doing a research and development on new antibiotics, on genes that are going to be more receptive to this particular antibiotic, or on ways of reducing mutations in those genes. So those are the R&Ds, regulatory and manufacturing components, and then supply chain diagnostics, where we've actually been describing in this particular presentation, prescribing practices and dispensing practices, and those are the things that we've actually been looking at. Core elements, we've seen that leadership, commitment, accountability, drug expertise, interventions or actions, reporting, M&E or monitoring and evaluation, education, training, communication, and quality improvement are very, very important core elements of an antimicrobial stewardship, which can be curated in different setups. If you have a small hospital, you have a bigger hospital, you can just put these things together, put a team together, and work from where you are. Then interventions such as could be national level, where decisions and policies are going to be developed. They're going to trickle down to county level. They're going to trickle down to hospital level, which could be level 6, level 5, and level 4 hospitals, and then health facility-based level, or 3 and 2. Then community or pharmacy-based, interventions, then community-based interventions, which include things such as washing hands, boiling water, using cleaning fruits before eating them, and such kinds of simple, basic measures that are going to prevent the acquisition of bacterial infections. Then how are we going to establish antimicrobial stewardship as a program in our specific hospitals? We're supposed to form an AMS committee that's comprised of those particular specialties I mentioned. There's supposed to be a management representative, a person from the lab or the microbiologist, a person from the pharmacy, a person from the clinical team who is specialist in infectious diseases, and a person, if you have a public health or an IPC expert, can be part of that particular committee. Then, of course, you have to develop a business case development where this thing is supposed to be sustainable. You cannot be in a hospital that is a level 2 hospital, and then you come up with an antimicrobial stewardship committee that is the same as that one at level 6 hospital. It's not going to make business sense, and your directors are going to shut you down. But if you come up with something that makes economical sense in your setup, something very simple, and present it to the management, they're going to adopt it and help you, maintain these particular AMS committees in your setup. Then you can start with a single priority area. For example, poor prescription practices in hospitals. You just deal with that. So the clinicians are going to be having a standardized prescribing practice for antibiotics, and they're only going to prescribe where they're supposed to prescribe, not empirically covering every infection that a person is presenting with to the hospital. Then you use appropriate policies and guidelines. You have to educate staff and publicize your program to the entire facility and everyone who is involved, so that people may know that there is this program here. It targets this, or our objective is this, and this is what we're trying to do to curb the spread of antimicrobial resistance in this particular hospital, and lead to reduced hospital stays, reduced rehospitalization, reduced mortalities, and those kinds of poor reports from our specific hospitals and environments. And then we have to implement those activities and continuously improve through periodic meeting and assessing how you performed in the last quarter or the last month. Then you implement activities, assign roles, assign gaps that have been identified to different peoples, give timelines for implementation, and then review them after another period of time, maybe say 3 months again, and then see how effective you are. Antimicrobial Stewardship Committee or AMS is going to be working in your particular hospital. So you realize that there is reduced infections that are acquired in the hospital. There is improved IPC. There is reduced antimicrobial resistance, and everybody is happy in the hospital. The directors, there is reduced costs. People can even sue you for acquiring an infection in your setup because of poor hygienic conditions in your hospital or your setup, or using dirty equipment, or you yourself as a healthcare provider being a source of an infection. Yeah. So these are the things we can be able to put together, and I've just put in a blanket cover of it so that we can be informed and we can be able to comfortably create and sustain antimicrobial stewardship committees or programs in our hospitals and lead to improved antimicrobial resistance patterns locally, and then trickle to county, trickle to the nation, to the continent, then globally, because that is how data is shared. So that's all from me, and back to you, I think, Frederick, for now also to take over on the next session as we look at the references that I used for this particular presentation. Thank you so much. Frederick, back to you.
Thank you so much, Cosmas, for that very able presentation. I must say that it was quite insightful and also very elaborate. And I'm sure that our members here and participants who have been able to tune in have been able to get something from the presentation. And for sure, AMR is something that we all need to pay attention to. And maybe at this point, I want to invite anyone who has a comment. It can come in form of a question, or you can also maybe want to raise your hand and maybe just make some remarks. We are open to that. You can just raise your hand. I'll be able to unmute you and you shall be able to maybe make your remarks. So at this point, I'm inviting questions. Anyone who has a question, you can also type in the chat box, and then we can be able to discuss just amongst ourselves. So I think up to there, I want to appreciate everyone who has found time to join. And also thank you for the kind comments, especially regarding this presentation. And maybe I'm going to allow anyone who has a comment or a question to type in the chat box, or to raise your hand. I'll be able to allow you to speak. So if you are here and you want to speak, just raise your hand. I will be able to allow you to do that. So once again, feel free. This is interactive. This is interactive. And Calvin's Odoyo, I can see you, and maybe I'm going to unmute you and maybe you unmute yourself, and then you can speak. Calvin's, if you can hear me, just unmute yourself and proceed to make your remarks.
Oh, sorry. It is the hand is raised by mistake. Though I will congratulate the presenter for a good work.
Okay, thank you so much, Calvin's, for the remarks and also for your comment. I can also read just a few of you who have written. This is Bernard Kanzo saying good. And then Georgia Nakini saying nice and informative presentation. And then maybe I'll bring in a question from Wilfred Moriasi. And he's asking, do clinicians know that we are developing serious resistance? How can we part and partially, okay. I think he's asking, how can we be part of making decisions for drug prescriptions? Yeah, so thank you, Wilfred. I'm sure Barasa has something to say because this is really a global threat. Barasa, back to you. Cosmas, did you hear that?
Oh, yes, I heard it. I had muted myself, sorry. Um, So clinicians do empirical prescriptions, sometimes even for conditions that are not, you know, that are not indicated for antibiotic use. And it's important that the lab takes part, and you can be involved through. I've seen ward rounds where cases are brought to you. No, the cases are brought up, and you discuss from your specific understanding and your specific scope of practice. So you can be able to bring your input in that particular, at that particular juncture, if you're given a chance. You can also bring your input through these kinds of training so that you can inform them that blanket treatment is not very effective, but targeted treatment is effective. You can also be verbal enough if you know what you're doing. You can be able to increase the use of microbiology lab in your case, so that not only all UTIs are going to respond to azithromycin. Azithromycin, I don't know what people love about it when it comes to UTIs. You see a person having a UTI, a clinician has already prescribed azithromycin. They're going to buy, or they're going to get it over there. So you can see that for this UTI, you can be able to get the right antibiotic through this particular procedure here. You can do a culture and sensitivity and provide information that's very, very, very applicable to that particular clinician. So it depends on what you can bring to the board, on the table as a laboratory practitioner, so that it can be appreciated. But if we sit back, the problem with the labs is that we sit back with the information that we have and let the clinicians guess and do what they're supposed to do. But we are supposed to help them do the right thing and also help them make the patients get better by prescribing the right drugs. So perhaps this information, I think for the person who understands who asked for our role, that's basically what you can be able to do on the ground and lead to increased standard prescription practices in those setups. I think that's back all, and back to you.
Thank you. That's quite clear. I think that helps. That helps very much, Wilfred. So maybe I can get to the next couple of comments. And this is Simon Letting saying, thank you for the good presentation. And I just wish you clarify how the abundance of bacteria in humans in comparison to other microorganisms can contribute to a form of mechanism of drug resistance. So, Cosmas, do you have any insight? Cosmas, did you hear me?
Yes, Frederick, I heard you. And that is because the most commonly encountered infectious microorganism is the bacteria as compared to viruses, which could be able to self-clear. Bacteria are the ones that require treatment most of the time, and viral are self-limiting. So that's why there is, of course, also the abundance of the human flora. We understand the human flora, yeah, that can also be a normal flora in one area, yeah, as I mentioned, and this normal flora could be a pathogen elsewhere. For example, E. coli is a normal flora in the gut, but if something happens and this E. coli finds itself into the bloodstream, it's going to be a pathogen there. So the abundance of organisms in the GIT, yeah, and even you can even cough it up and even breathe it into your lungs, yeah, so that now the GIT infection is going to infect another region, yeah, and the GIT normal flora is going to colonize another region of your respiratory tract system, and it's going to cause an infection there. So the abundance of bacteria comes in, and abundance of normal flora comes in that particular play, and it can be able to cause different pathologies or abnormalities or infections elsewhere, depending on the kind of organism that you're actually dealing with. So the abundance of bacteria is because of the abundance of normal flora everywhere, yeah, which could be pathogens in other regions of the human body.
Very well, thank
All
you
right,
for
back
that.
to you, Frederick.
Thank you, thank you. So I can see many of you really appreciating the presentation. Thomas Odera, great presentation. Meshak Ndege, nice presentation. Damakri Nombogo, very informative. And then Faith Njuguna, thanks a lot. It was a great presentation. And then Bernard Kanzo is talking about it's high time that sample culture become basic in every lab. Robert Wafula, good presentation. Andrew Chieng, very elaborate. I think there are two more questions that we can read. That is from Leonard Walukana. Can we say something on differences between chromosomal and non-chromosomal resistance?
Leonard, chromosomal, if you're talking about a chromosome, you're talking about something that's affecting something at a molecular level. You're talking about genes. You're talking about specific mechanisms that are affecting the genes that are going to lead to increased resistance patterns. Non-chromosomal mechanisms or non-chromosomal issues are things that are going to be away from the genes. Could be enzymes, could be efflux mechanisms, could be any other thing apart from genetic, genetic manipulations that the bacteria has against the antibacterial that are going to be used. I think that's all I can be able to mention on that. Unless someone has something to add on that, perhaps from my end, that is it.
Thank you. And then maybe there's a final question here, and this is from okay. This is I think I'm getting the question. Sorry. And this is from Leonard Walukana. I think saying thank you for the elaborate presentation. Any new information on multi-drug resistant Nairobi gonorrhea? Yeah, thank you, Leonard. I know this is an emerging area, especially we know that we document and even test for syphilis very well. And I think this is done even at the PMTCT settings. But I think there's a small area that needs some attention, especially gonorrhea, chlamydia, and maybe other STDs. But I think this is a new area. I don't know whether Cosmas, you have anything to say. But Leonard, we have a presentation that is coming regarding this area, and maybe, and if the speaker has something to say, he can comment. But we have lined up a presentation touching on this area. I am aware that there is some information that needs to be shared with the public. Thank you.
Yeah, so I'll leave it to the Nairobi teams, those ones who are on the ground. Perhaps they have done susceptibility profiles on this gonorrhea isolated from there, and the presentation is coming up. I think we'll leave it there so that they can be able to comment on it later on, Frederick.
Thank you. Okay, so anyone who is asking for CPDs, Georgian, kindly just check your email. It's usually sent there within 24 hours. And also many of those emails go to your spam box. So just before you reach out, kindly check your spam box. Most likely your certificate is there. And if it's not there, there's a communication to that effect. Either, and maybe if you've checked, you go ahead and fill in the complaint form, and then we shall be able to address it conclusively. I think that helps. Otherwise, I think we've come to the end. I can see a few more comments. Daniel, Thomas Odera, thank you. Great presentation. Keep it up. Just for to teach, saying nice presentation. Fred Mose, very informative. And then Nicholas Kirinya, good presentation. So I think, colleagues, we have come to the tail end of today's presentation. And we are also urging you, if you have any area that you feel has not been addressed well, you can always reach out so that we can always plan and see how we can capacity build ourselves. Otherwise, it was such a wonderful presentation. And back to you, Cosmas, for your closing remarks.
Okay. Now, this is just to encourage people to pick up microbiological work. You can start small. Yeah, you can start manual. It's not a must for you to have automated, expensive equipment for you to start a microbiology and culture labs. You can start small with what you have, and perhaps help the clinicians and help the patients at large, and also play a key role in curbing the antimicrobial resistance. So thank you so much, and thank you for tuning in. Until next time, back to you, Frederick.
Thank you for that, Cosmas, for a very wonderful session. And I think I also want to thank all the participants who found time to join in. And I think it was such a wonderful and a great learning session. And until next time.